at Zero, the End of Prostate Cancer. Our guest presenters are Colonel Paul Taylor, a stage 4 prostate cancer patient and Zero board member, and Dr. Alicia Morgans from the Feinberg School of Medicine at Northwestern University. Dr. Morgans also chairs Zero's Medical Advisory Board. Our program this evening is hosted by Zero. Our mission is to end prostate cancer by advancing research, encouraging action, and providing education and support for men and their families. We're very grateful to our sponsors, both of them, Dendreon and Astellas and Pfizer Oncology. As an overview, we're expecting the webinar to last about an hour. In a moment, I'll give a general overview of Zero as our organization and introduce our presenters. And then I'll hand it over to Dr. Morgans to start our presentation. After the presentation, time allowing, we'll go into a question and answer session. If at any time during the presentation you have a question, please type it in the chat box. I'll be sure to flag it so we can send it over to Dr. Morgans and Colonel Taylor to address. And we'll try to get in as many questions as possible. Also, everyone smile because right now this webinar is being streamed live on Facebook. So feel free to post it with your friends and family and see if we can really spread awareness this evening. We're also recording the webinar and posting it on Zero's website, which is zerocancer.org, and that will be up in the next couple of days. So if you missed it just a moment ago, our organization is Zero, the End of Prostate Cancer. We're a leading nonprofit organization with a mission to end prostate cancer. We work to advance research, improve the lives of men and their families, and inspire action. Our ultimate goal is to create Generation Zero, the first generation of men free from prostate cancer. We'll meet this goal with your participation in our National Run Walk series that we have in about 42 different cities across the country from coast to coast, grassroots advocacy to fight for research and access to care, and in education and support programs like this one. It's the holiday season, and holiday season is a busy season, so thank you for taking time to help yourself or a loved one by joining us tonight and getting informed about advanced prostate cancer. Thank you also to Amanda Singer, who's working our logistics tonight on her birthday. Thank you for sharing your birthday with us, Amanda. Happy birthday. And finally, thank you to my dear friends, Dr. Morgans and Colonel Taylor, for taking the time tonight to share your insights with us this evening. Both of them are the kind of people that you want your kids to grow up to be. First up is well, if you're going to talk about me, kind of the third wheel in this. First up, Dr. Taylor, Colonel Taylor is a retired Army colonel. I'm a proud dad to 3 amazing daughters and continues to keep our country safe through his post at FEMA. So if you don't want to get through all of this bio, he's the real Mr. Incredible. And then we're also joined by Dr. Alicia Morgans. She studied at Penn, did her fellowship at Dana-Farber, worked at Vanderbilt University, and is now at Northwestern University. This bio pretty much translates to being fantastic and awesome. And so I'm going to hand it off to Dr. Morgans to kick off our agenda.
Great. Thank you so much, Jamie. And you are too kind to all of us. I do want to point out that Jamie has been leading Zero for many years now and has really transformed the organization into one that provides top of the line education for patients and their families, as well as raising awareness for the disease, increasing awareness in terms of screening, raising money to help patients through organizational efforts that provide patient navigation as well as research dollars. So really tremendous work, and he really downplays all of this. And so if you have the opportunity to read about him and his efforts, I do encourage you to do that as well. So this is just an agenda slide to give you a taste of what's to come. So we'll go over what advanced prostate cancer is and what some of the treatment options are for advanced disease. We'll review some clinical trials as well as thinking about how we manage side effects and live with the disease and not let it kind of manage us. as well as how we think about staying informed and involved by asking questions of your doctor and using other resources as well. So why don't we get started? So advanced prostate cancer comes in a lot of different forms and flavors, and this is really just a slide to help everybody sort of organize their thinking around what is advanced prostate cancer. I would say that localized prostate cancer is the other form, and that's really prostate cancer that's all in the prostate, and it has either just been treated with usually radiation, surgery, or sometimes active surveillance, or is about to be treated. But after that happens, if the disease starts to come back, we call that advanced prostate cancer. The earliest stage of that is biochemical recurrence, and biochemical recurrence is a form of prostate cancer where we can measure something called PSA, or prostate-specific antigen, in the blood. It's a protein that's made by prostate cancer cells, and the only sign that an individual has prostate cancer after treatment is that we can't see on scans is called biochemical recurrence. So biochemical recurrence is when we can measure PSA, a protein in the blood, showing us that there are prostate cancer cells somewhere in a man's body, but when we do scans, we can't find the cells on scans in any group that's large enough for us to see them on a scan. If men have biochemical recurrence, they can develop something called castration-resistant prostate cancer. And you can have metastatic or non-metastatic castration-resistant prostate cancer. What that means is that you've tried to treat the prostate cancer with something called androgen deprivation therapy, which is a therapy that lowers testosterone levels in men's bodies. But despite having low testosterone levels, the cancer continues to grow. The reason that androgen deprivation therapy, or lowering testosterone levels in men, is really useful is because testosterone is sort of like the sugar for prostate cancer cells. It's the food or the fuel that prostate cancer cells need to grow, survive, spread, and cause trouble. So if we can take testosterone out of the system, or essentially cause castration in men, that can really starve the cancer cells, causing some of them to die and others to hibernate, hopefully for many, many years. When cells or prostate cancer cells become resistant to that, they're called castration resistant. That means they can grow without testosterone, and that's just another disease state that we have ways to treat, but it's different from what we call hormone-sensitive disease. Metastatic prostate cancer means that the prostate cancer cells have spread outside of the prostate, typically have either come back after radiation or surgery, or sometimes is newly diagnosed with cancer cells in bones, lymph nodes, or other organs. And then metastatic castration-resistant prostate cancer is a combination of metastatic prostate cancer that we can see with scans, so spread outside of the prostate, but is also resistant to that androgen deprivation therapy or low testosterone in the body. Next slide. So there are multiple treatment options for these forms of advanced prostate cancer. We'll go through some of them in just a few minutes. The treatment for advanced prostate cancer can slow or stop the spread of the disease, but can't cure the cancer in all of those states except sometimes biochemical recurrence. If patients have just a PSA that's rising after treatment with surgery or radiation, sometimes we can cure the cancer, but in most cases, and certainly in the case of metastatic prostate cancer, we at this time don't have the technology to cure the cancer. And so we use treatment to help men live longer and to help them live better, improve their quality of life, reduce their symptoms like pain and discomfort. And while men are living with prostate cancer, with advanced prostate cancer, doctors certainly routinely perform tests, often blood tests and other imaging tests to monitor the disease. But men can really live for many years and sometimes decades with advanced prostate cancer. So if we can go to the next slide, let's just get Colonel Taylor's or Paul's perspective on living with advanced prostate cancer. Do you have just a couple words for us, Paul?
Sure. Well, thank you again. Thank you, Jamie, and thanks to everyone that's on the line. Alicia is the expert, but just by way of giving you my credentials, outside of what you saw on the slide, I was diagnosed with advanced prostate cancer in July of 2012. So I've been living with this thing for about 5.5 years. It is castrate resistant, and I've have experience with a lot of different forms of treatment, from standard ADT, androgen deprivation, on like something like Lupron. I've been taking continuously for 5.5 years, still on today, to some of the newer androgen treatments that we'll discuss later, Zytiga and Xtandi. And I've also had a radical prostatectomy, which is where they remove the prostate and as well as an immunotherapy called Provenge, which we'll discuss as well. And I've also done chemotherapy. So I've been around. About the only thing that I haven't done in terms of standard treatment is radiation therapy. I think from my perspective, I think what Alicia said is exactly right. I mean, the landscape for prostate cancer treatment is changing very rapidly, and I think that every year of survival brings newer and better treatments. So there's a lot of hope out there. A couple things that you can do for yourself, though. One, you have to be an empowered patient, right? I mean, in the course of my journey, 5.5 years, I've been treated by about 4 or 5 different doctors. One, because I wasn't afraid to, if I didn't get a good feeling from a doctor, and if that doctor was not willing to see me as a peer in the relationship in terms of treatment and discussion of treatment options, I left and went and found another doctor. I mean, it's too important. You only have one life and one try. You're not going to get very many tries at this whole thing. So I had decided very early on, I was diagnosed when I was 41 with metastatic disease, that I would be very aggressive in terms of my treatment. And I was willing to continue to look until I found a doctor that thought the same way. That approach isn't going to work for everyone, but I think that you have to kind of take charge of your treatment regimen, and you have to be your own best advocate. And if your doctor's not willing to, not comfortable with that level of involvement, then you probably need to look for another doctor. You have to be informed. There's a ton of people on this webinar tonight, and I think that I'm preaching to the choir on this point. But there are folks out there that once they find out they've been diagnosed with cancer, they just don't want to know. And while everyone is different in terms of how they respond to the disease, I think that if you are educated and if you look at all the options and you do your homework and you are involved in your treatment and the decision-making protocols behind that, you're ultimately going to do better. Because really what it's all about is buying yourself the most time at this point. If you're diagnosed with advanced disease, the bad thing is that the clock is ticking a little bit. There's no reason to believe that guys can't live a long time. And I've talked to folks in my journey who were diagnosed with advanced disease 20 years ago. So there's a lot of hope out there, but you have to realize that you can't just be complacent in the process. I think that's probably good for now. But I'm happy to answer questions from a patient perspective. Like I said, it's personally important to me to get involved and kind of give back to the community, which is why I'm involved with Zero. And Zero is doing a lot of great work, like Jamie and Alicia mentioned. But everybody has their own way of kind of working their way through this disease. So I look forward to talking with you all.
Great, thanks so much, Paul. So let's get into some of the more specifics regarding treatment options. And we'll start with hormonal therapy, which is, again, directed at the testosterone in the system because, as I said, testosterone is the food or the fuel. It's like the sugar that the cancer cells want to eat. And if you can get rid of that, you can stop stimulating the cancer cells to grow, divide, spread, and cause trouble. So hormonal therapy, otherwise called androgen deprivation therapy or ADT, stops the body's production of testosterone in its most simple form. This can be done either by surgical castration, which is actually the removal of the testes, which has to be done on both sides, or medical castration, which is using either injections, actually often a combination of injections and pills to lower testosterone. So many men may have been treated with, who may be on this call or may know people who have been treated with injections that are GnRH agonists or antagonists. This is the backbone of androgen deprivation therapy, and those are medicines that we'll get into some names in the next couple of slides, but that serve to stop the testes from making testosterone. There are additional medicines that are pills that can be added to those injections that further stop the production of testosterone, like abiraterone, or block testosterone from activating cancer cells at the level of the prostate cancer cell, like enzalutamide. Hormone therapy is most often used in combination with radiation or after surgery for high-risk localized prostate cancer, and it can also be used alone or with other treatments for metastatic prostate cancer. So really, this is the backbone of therapy. There are multiple types of hormonal therapy. In the middle there, you can see GnRH agonists, or the antagonists that we have. This stops the signaling from part of the brain, actually, that signals the testes to make testosterone, so it stops that signal. The anti-androgens are medicines that block the testosterone from activating the cancer cell. I think of them as a muzzle that goes over the mouth on the cancer cell that's trying to eat the testosterone. They're sort of like a muzzle on the mouth to stop the testosterone from getting into the cancer cell, activating it, and allowing it to cause trouble. Some of the examples of that are things like flutamide, bicalutamide, nilutamide, and enzalutamide. They've been around for a long time, with enzalutamide being the newest. And then there are steroid synthesis inhibitors. These are, in other words, medicines that stop the production of testosterone, but they stop the production of testosterone that happens in the cancer cells themselves when they start to figure out how to make testosterone, as well as testosterone production that happens in the adrenal glands. Those are just other glands in the body that happen to make testosterone in addition to the testes. And these are medicines like abiraterone and ketoconazole. So the backbone of all these therapies is going to be the GnRH agonists. These stop, or agonists or antagonists. Next slide, please. And these stop stop the signaling between the pituitary gland and the testes, and stop testosterone production from the testes. The testes make the vast majority of testosterone in men. And so drugs in this class include things like Zoladex, Trelstar, Eligard, and Lupron, and these are the agonists. These are administered as depot shots, so these are shots that you get either once a month, every 3 months, every 4 months, every 6 months, or once a year, and they are released slowly over time. So that's what makes them a depot shot. But at the beginning of treatment, for the very first treatment, these actually cause a flare in testosterone or an increase in testosterone with the first injection. This has to do with the complex signaling that occurs between the pituitary gland, part of the brain essentially, and the testes, and lasts for about 10 to 14 days right when you start the first injection. And so when you are starting that first treatment, we do have patients take a pill in addition to these shots for the first 30 days usually, that blocks the testosterone from getting into the cancer cell. One of those anti-androgen medicines, a muzzle on the mouth of the cancer cell to block that flare, that increase in testosterone from stimulating the cancer cell. There are other options, so GnRH antagonists, also called degarelix, and they don't cause the flare. So this is a newer class of drugs, also stopping the testes from making testosterone, and they also act on the brain, but instead of causing a flare, they actually cause an immediate decrease in testosterone. Degarelix is the name, also called Firmagon. That's the brand name. The difference, or the main difference that a patient may notice with these medicines, besides the fact that they don't cause the flare, so you don't have to take that 30 days worth of pills, is that these are given as a monthly shot. There aren't options as of yet for these to be given as a 3-month or 4-month or 6-month shot. But one of the nice aspects about them is that you do not have to take that 30 days worth of pills when you start the first shot. So degarelix is one of those, is the only option in the GnRH antagonist group of medicines. Anti-androgens have been mentioned a couple times. These are pills that block the flare from that rise in testosterone associated with those other drugs. Bicalutamide is an oldie but a goodie. It's also called Casodex, and that's what we used when we were first starting the GnRH agonists that cause that flare. And they are also used in metastatic castration-resistant prostate cancer, so the most advanced type of prostate cancer, when the disease is both spread outside of the prostate as well as being resistant to the androgen deprivation therapy on its own. And the medicine used for that is enzalutamide, a very, very potent muzzle on the mouth of the prostate cancer cell, blocks any testosterone that's coming from the adrenal glands, for example, from getting into the prostate cancer cell and stimulating it. Next slide. The steroid synthesis inhibitors that we use most commonly are abiraterone acetate and sometimes ketoconazole. Abiraterone is also called Zytiga, is a newer medicine that stops the enzymes in the adrenal glands and the prostate cancer cells themselves from making testosterone, also used in that most advanced form of prostate cancer, the metastatic castration-resistant prostate cancer. Next slide, please. These hormonal agents, or hormonal blocking therapies, I should say, have multiple side effects, not what we would expect from something like chemotherapy, the fatigue, hair loss, and risk of infection, but they have their own set of side effects that can also be really life-altering and things to be very aware of. And we don't like to use any medications, including these, unless we absolutely have to. But when we do, they're incredibly potent and helpful and help men live longer and better lives. But the side effects we have to think about are things like breast pain or enlargement, loss of libido, and hot flashes. Again, we're causing testosterone levels to go really, really low. And it's similar in some ways to what happens when estrogen levels go really, really low in women who are going through menopause. Different in many ways, but that's the medical condition that I would say is most closely related. In addition, just like women who go through menopause, lowering testosterone with androgen deprivation therapy causes bones to thin and increases the risk of osteoporosis, as well as increasing the risk of fracture when people's bones are thin. Men may find that they lose muscle mass and have an increase in their belly fat, and also can have an increased risk of heart disease, things like heart attack when all this happens, and there certainly can be mood swings as well. But despite all of these changes, that I know that sounds like a lot, these medicines are usually really well tolerated, and you get a nice bang for your buck in terms of helping men live longer and better lives. And so typically men find that they're worth the effort. Next slide, please. So Paul, I know you've lived with these medicines. Can you speak to the challenges that you might have had and how you overcome some of them?
Sure. I think, the thing that I would say first of all is, don't be scared of the side effects, right? I know that, it looks pretty daunting when you look at that list and you think about things like loss of libido, hot flashes, right? Weight gain, loss of muscle mass. All of those things have happened to me. But, I can tell you that as a person that has lived now on androgen deprivation therapy for more than 5 years, really almost 6 years at this point, the side effects are, one, you can live with them, right? And two, I think that there are a lot of things that you can do to help mitigate the effects of those once you get used to them and once your body gets used to them. The thing that I would say would be my number one priority and message to everybody out there is please, please, please find a way to get regular exercise while you're undergoing androgen deprivation therapy. You would be surprised at the amount of side effects that you could head off and the quality of life that you'll get, an improvement in quality of life just from 30 minutes of exercise a day. Depending on your age, depending on what you can do, even going out and walking for 30 minutes a day is really, really going to help. So don't be worried. Don't be one of these guys that I hear from all the time that says, hey, I don't want to take Lupron because I'm afraid of the hot flashes. Hey, I've been living with hot flashes for 5.5 years, and I still work every day. I work in a business community. It's just one of those things that I have to do, to be able to get on with my normal life and overcome the adversity associated with this disease.
Thanks so much, Paul. Were you going to say something, Jamie?
No, I think that was feedback. Thank you, Paul.
Oh, sure. Thank you, Paul. And I would also emphasize that when you look at the list of side effects, it is incredibly daunting. But men living with this illness, I think, really find ways to get around things, and it does become part of living with cancer. And you can absolutely do it. There is no reason in many cases why men can't continue working if they choose to not work. That's one thing. If men are retired, that's another thing, and that's a great thing too. But many men work on androgen deprivation therapy, and they do their jobs the way that they normally do. And there's always ways to compensate and get around things, and don't just look at the list of side effects and be afraid to try. I really encourage you not to. And I also would say that most people don't have all of the side effects. It might be that you have one or two, and again, I'm pretty certain that you can make it work. I have great confidence in all of you. The other treatments that we think about using in advanced prostate cancer include things like radiation therapy. Radiation can be used to stop cancer cells from growing once they've spread to the bone, and this can be external beam radiation or systemic or injected radiation. Next slide, please. External beam radiation is the traditional type of radiation that we think about, where an individual lies on a table and there's a beam aimed at a bone that's causing him pain or that may have fractured, for example, and the radiation can strengthen areas that are weak. It can relieve pain, and it can be given as a single treatment or over a series of treatments, maybe over a 3-day course or a 5-day course. Individual treatments are about 10 to 15 minutes long. It's kind of like lying in a tanning bed, and so it's a relatively short period of time. But if you have more than one treatment, it's given over consecutive days in most cases, so it's not all given in one day. But it's interesting, and it's important to know that if you receive radiation for pain, for example, to a bone, the maximum pain relief may take several weeks after you've even finished treatment with radiation to actually kick in. So it's often a pretty quick pain relief, but it can take weeks to reach its maximum effect. Systemic radiation is a radiation that's infused through a vein, and it travels through the blood and gets into areas in the bone where there's prostate cancer. And once it's in there, it actually undergoes radioactive decay, or has a little radioactive explosion right in that local area, and can kill the prostate cancer cells in that area, greatly reducing bone pain. And also, if treatment includes radium-223 or Xofigo, it can help men live longer. Samarium and strontium are other options. The side effects are typically both can cause fatigue and low blood counts, and then external beam radiation can cause other side effects depending on what area of the body you're radiating. Infused radiation can cause the fatigue as well as nausea, diarrhea, and low blood counts. Immunotherapy is another treatment option. This is an infusion, again, that includes infusing cells that are actually your body's own trained cells that are trained to fight the prostate cancer cells. So it is a way of teaching your body's immune system to fight the cancer cells and remove it from your system. The treatment that's available is called Sipuleucel-T, and this is actually a whole process that involves removing white blood cells from the man's body, having them essentially shipped to a facility that trains them, does a special process to train these cells, and reinfuses the cells back into the patient about 2 days later. And this treatment can educate the man's immune system to fight prostate cancer cells and help to get rid of as many as possible from the body. Next slide, please. The side effects from immunotherapy are similar to what one might experience with the flu, but on a much lower scale. So generally there are very few side effects, but the ones that one might feel are at the day of the infusion or at the time of the infusion, sometimes a low-grade fever and some backache, maybe a little bit of fatigue, muscle joints, and aches and chills. But generally by the day after the infusion, there are no further effects. Next slide, please. Chemotherapy is a set of treatments that are used to kill rapidly dividing cells like cancer cells. The chemotherapies that are most effective in prostate cancer include docetaxel or cabazitaxel. These are taxane chemotherapies, both found to be effective in prostate cancer. And these are used both in metastatic prostate cancer after the hormonal pills have failed or before, and for men who have newly diagnosed metastatic prostate cancer when they're first starting therapy. So we use chemotherapy in a variety of situations. Chemotherapy can cause low blood cells, low white blood cells, and that's the immune system. So it can make the immune system less able to respond to infection. It can also cause an anemia, which is a low red blood cell count, and sometimes may require a blood transfusion to make up for that. It can cause nausea, constipation, mouth sores, hair loss, fatigue, as well as nerve damage that you would feel as numbness or tingling in the fingers or the toes, and sometimes an allergic reaction. Bone health is also really important in prostate cancer because bones become thin over time related to the androgen deprivation therapy, and bone metastases can make bones weak. And so bisphosphonates or denosumab are two types of medicines that make bones stronger. They don't directly affect the prostate cancer cells, but they make the bones stronger and prevent them from having fractures or prevent them from having other complications associated with the prostate cancer. In addition to using those medicines, weight-bearing exercises and using calcium and vitamin D can all help improve bone strength. Bone metastases are when the prostate cancer has moved into the bone. It's still prostate cancer cells. It is still prostate cancer. It just lives in the bone. It's got a new neighborhood. I had a patient the other day come in who unfortunately thought that he had bone cancer, not prostate cancer that was living in the bones. And those are two very, very different things. And frankly, having prostate cancer is a much better situation than having a traditional bone cancer like a sarcoma. Those are much more difficult to treat. So it's a good thing to have prostate cancer living in your bones rather than bone cancer. But that can put you at risk for these things like fractures or cord compression, which is cancer that's pushing on your spinal cord, and these can be painful events. And so using medicines like bisphosphonates or denosumab can reduce the risk that those things will happen, and treatment for those kinds of things can include radiation, systemic radiation or external beam radiation, as well as sometimes surgery. So just to summarize, some of the side effects in the treatments, hormonal therapy can cause side effects related to low testosterone, so loss of libido, loss of muscle mass, fatigue, hot flashes, and bone loss. Radiation can cause fatigue and low blood counts. Immunotherapy can cause, just in the very short term, fever, muscle aches, and fatigue. Chemotherapy can cause hair loss, fatigue, risk of infection because of low blood counts, nausea, numbness, and tingling from nerve damage. And bone treatments can cause some fatigue, sometimes diarrhea and nausea. They're, again, not directed at the prostate cancer cells specifically. They don't treat the cancer, but they help to prevent the complications from the cancer related to the bone. Next slide, please. So, Paul, can you give us any further perspective on any of these treatments or any comments that you might have?
I think the thing to remember is that there's no one-size-fits-all for every prostate cancer patient, right? So some patients are going to benefit based on their circumstances and their disease progression, and maybe some advanced testing that your doctor might do, like genetic profiling, or just, other blood testing. The doctor might decide that a very sequential single therapy is best, right? So you would do one type of therapy and then, achieve hopefully many years of benefit out of that. And when it stopped working, then you would progress to another one, to another one, to another one. That's more of the traditional mindset, but for a lot of men, that can work for a very, very long time. There's other men, like the decision I made early on in my treatment, who thought that the best survival chance was to start combining these therapies. And certainly I think we're seeing a lot of research now that points to the fact that, prostate cancer is a very complex disease. And men are oftentimes able to get a greater benefit by combining and sort of hitting with a 1-2 punch or the 1-2-3 punch, or maybe a kick at the same time, right? So that you're hitting prostate cancer from all directions, and the cancer never really has time to react. But I would never say that's the right solution for everyone. I think you have to be able to, do your own research and have a good discussion with your doctor about which is the best for you. And you have to understand all the options, that Alicia just went over, in order to have that kind of conversation with your doctor. You have to know what the menu is. For example, we mentioned chemotherapy. Traditionally, chemotherapy was something that was used when nothing else was working, right? You progressed through all your treatments, and then sort of the last thing you did was chemotherapy. Well, there's been some recent studies that have shown a survival benefit to men who are newly diagnosed with metastatic disease. That was certainly the case in my particular case, where I did a course of Taxotere, one of the chemotherapies approved for prostate cancer, and I did it very early in my treatment regimen. So, again, you have to kind of look at the individual circumstances. You have to look at, how robust and what types of treatments a man wants to take on too, because I think that's one thing you have to realize. I was pretty young when I got diagnosed, so I was willing to maybe run a little bit of a risk in terms of being aggressive and thinking, well, there may be a lot of side effects, but I'm young and I'm pretty healthy, and I think that my body is ready to kind of withstand some of those side effects. If I had been 80 and diagnosed, it might have been a slightly different discussion with my doctor, because we might have said, well, we might recommend these things, but not this, because we just, I'm 80 and I don't want to deal with those particular side effects. Quality of life is more important to me right now than some of the side effects that come from that particular treatment. So, again, it all goes back to a productive and informed discussion between you and your doctor, whether you go for more of a sequential or a combined therapy. But I think that there are lots of options out there for men. And the good news is, I think that we're getting so many options in terms of treatments at this point, that it's not becoming a question of you're just going to do this. You're going to go to the doctor and they're going to say, we're going to treat you with option A or maybe option B. Now you and your doctor are going to sit and you're going to look at all these options, and really it's just about finding the right sequence and potentially combination for your particular stage in life and your cancer.
Thanks so much, Paul. So we can go to the next slide. So let's talk briefly about prostate cancer clinical trials. A clinical trial can sometimes offer a new treatment that's not otherwise available, or a combination of drugs that are not available off of a clinical trial. So when Paul was talking about whether these treatments might be better if we use them in combinations of 2 or 3 or more, or what the sequence of these treatments might be and what's the best way to do things, a lot of that information is figured out in a clinical trial. And so a clinical trial may be the best way for you to get the cutting-edge treatments for this disease. The goal can be to discover a new therapy or find a new way to help put therapies together that are already existing to prolong life, improve health, and certainly to fight prostate cancer. And there are multiple types of clinical trials that you need to think about as you're making these kinds of decisions. Therapeutic trials are trials that are performed to identify new effective medications or combinations that can prolong your life. Supportive care trials are trials that are done to reduce the symptoms related to treatment, or to study things like exercise, lifestyle, and diet modification on prostate cancer outcomes. And quality of life studies are looking at methods to improve quality of life, reduce complications of disease, and also to reduce complications from treatment. And these are also studies that could inform drug sequencing. So the greatest resource to identify clinical trials for any disease in the United States, at least, is this website called clinicaltrials.gov. And if you go to that website and type in prostate cancer or metastatic prostate cancer, and click on a button that says Find Clinical Trials. You should be able to find open and active clinical trials that may be options for you, and you can also find out where they're being performed to see if they might be available in your area. Next slide, please. Clinical trials are done in a very standardized fashion, and it's important to know that people are certainly not treated like guinea pigs. There is always something called informed consent, which is the patient's bill of rights to participate in a clinical trial. And the informed consent is a document that tells patients all of the risks, the benefits, the alternative treatments. It discusses what a patient's going to experience. It's very straightforward and uses non-technical language, and is a great way to make sure that you understand what the study entails and that you're agreeing to what you think you're agreeing to. The informed consent also very clearly states that if at any point you want to stop being involved in this clinical trial, you can do that, and you can continue your care with your doctor without having any repercussions. So it's very, very clear language in all of those documents. An institutional review board, or an IRB, is a committee of people who approve every single study's protocol and informed consent document to protect patients and ensure that the trial is being performed properly. And a data safety monitoring board is an institution of people, again, that follows along with all clinical trials that are being performed, to make sure that there is no more than minimal risk for patients, and that if any risks or problems are identified, the study can be halted early. Next slide. So every clinical trial is written with very clear eligibility guidelines, which means it defines what kind of person, what kind of cancer can be in the study, so that everything is standardized, because it is, at the end of the day, an experiment or a study. So everything has to be really very clearly documented, measured, and calculated perfectly. Next slide. There are several phases. The phase 1 form of studies is a unique opportunity for patients to have access to a drug that's often first time available in humans, or one of the earliest times the drug is available to people. And it is the purpose of these studies is to find the right dose, and to find the right dose to move forward in further phases of the study. But it is not the kind of phase that's going to very clearly prove that one drug is better than another drug to treat a given disease. The nice thing about a phase 1 study is that every participant gets access to the drug. There is no placebo in a phase 1 study. But the harder thing is that this is sometimes the first time the drug has been in a person, and so really this is one of the more complicated in terms of requirements for patients to come to follow up regularly, to have multiple blood draws, and sometimes more complicated protocols to make sure that they're being very, very closely monitored. Next slide. Phase 2 studies are the early efficacy studies, or the studies where they're relatively small, but they are the first sign that a drug is going to work to treat a given disease and is better than its predecessor, for example. And these are usually studies of less than 100 people, really to make sure that there's an early signal that things are effective with the drug. And the phase 3 form of studies are large clinical trials involving hundreds to thousands of people. These are often international studies, and they are definitively comparing one treatment to the standard treatment to define a new standard of care or a new therapy that should move forward. And these are some examples of clinical trials that have been recently performed, and again, they'll link to clinicaltrials.gov. Next slide. And some more examples of current clinical trial options. Next slide, please. It's important that if you are interested in participating in clinical trials that you talk to your doctor, because your doctor might have a trial available for you, or he or she might be able to say, let's go on clinicaltrials.gov together, and let's find a study that might be in your neighborhood or somewhere you can travel to go to have a clinical trial. So on to managing side effects. Next slide, please.
Yeah, it's there.
Oh, great, thanks. So many men do have long-term side effects from the initial treatment that they receive, whether that's surgery or radiation, things like incontinence and erectile dysfunction. And although these seem like really sticky challenges to solve and overcome, there really are treatments that are available, and if patients are willing to just talk to their doctors about them. Next slide, please. For urinary incontinence, there are surgical and non-surgical options to try to control leaking. And those involve things like certain Kegel exercises, behavioral modification. There are even things like penile clamps as well as medications. And then surgical options include slings and artificial urinary sphincters, among other things. Next slide. Erectile dysfunction certainly can be treated with things like pills, as I think most of us are aware from watching TV and seeing the advertisements, but there are a lot of other treatments, some of which are much more effective in the post-prostatectomy and post-radiation state, that it's important that patients are aware of, things like injections, erectile devices like vacuum pumps, as well as penile implants and prostheses, an inflatable pump. I've actually had some patients do so well with these. Actually, I've not had anyone who's gotten one say he was not happy to have it, but I've had several patients tell me that their urologist, the one who did the surgery to put these in, actually saved their lives. So these can be really life-altering for people, and it's important that if the pills alone are not working to combat erectile dysfunction and you're willing to try more, just ask your doctor, because there are options that may be much better than what you're doing right now. And it's important to just ask. So next slide. Next slide. So there are many questions you can ask your doctor, and we'll ask Paul's perspective on this in just a minute. But certainly understanding the results of your blood work, any biopsies that you've had, imaging, PSA testing is really, really important. What treatment should I get and why, and what are my alternatives? Those are also really important questions. And how likely is this treatment to work is another one. And how do we know if it's working? Next slide. Other questions to think about are, what are the risks, what are the benefits, what are the side effects, how do we deal with the side effects if they happen? Can I do anything like change my diet or exercise to try to prevent some of these complications? Just like Paul said, exercise is probably the most important thing you can do. Are there other supplements that I can use? Is there support for my family, my spouse? Are there other clinical trials that I might be involved in? So lots of questions to ask your doctor, and try, like Paul said, to find a doctor who matches with you and who you feel comfortable asking questions. Either a doctor or maybe a nurse practitioner, a physician's assistant, wherever you feel comfortable. Just make sure that you have a voice, because you deserve it. It's your life and your care. So Paul, it'd be great to hear your perspective.
Yeah, thanks, Alicia. All of those are great questions. I would say that the more foundational thing is, when you're getting ready to go to the doctor, make sure you have an agenda, right? Don't just go into the doctor and just kind of absorb, what they have to say without, thinking about the things that you want to ask them beforehand, all right? There's never been a time when I went into my doctor's office without my notebook and a bunch of things that I wanted to cover with the doctor to make sure that I stay on track. That's just my way. I'm kind of a type A Army guy. But if that's not your thing, make sure you bring somebody with you to the appointment, caregiver, your spouse, brother, sister, friend, okay, somebody who, can help keep the meeting on track, right? Because sometimes, if you're the patient, it's a little bit emotional for you. And, especially when you're early on in this disease, it can be a lot to take in. But I think that you have to make the most out of every visit that you make to your doctor. It's just important to be prepared. There's lots of sources of information. A lot of them can be found by going to the Zero website, right? And you got to watch out for all of the sources of information too. It's easy to get overwhelmed on the internet you just go kind of down a dark hole of too much information, and then you just get confused. So I would say stick with a couple things, right? Zero is a great source to get started, and that'll probably take you to a couple other places. But in terms of going to your doctor and talking with them, be prepared, make a list, talk to someone else who's affected by the disease, find a support group if that's helpful. And remember, once, it sounds bad, but once you're a prostate cancer patient, I joke with everybody that, there's nothing taboo. There's no shame, right? So when you talk to your doctor, don't be afraid to tell them about what's going on with your body. Incontinence, sexual dysfunction, side effects from treatment. Even something very small may not just be you. It may be an effect of the treatment. Or I think that the converse is just as true. Lots of times I found myself early on in treatment thinking that every single ache and pain was somehow related to my cancer, when it wasn't. I was just getting a little bit old. I had a little arthritis. I worked out a little too hard, or I hadn't worked out hard enough. Don't take yourself down that path either. But don't be afraid to discuss all those things with your doctor.
Thanks, Paul. We'll get to questions in just a minute. A couple of resources that are available through Zero is our program, 0360, which is a free and comprehensive patient support services call-in line. It's a 1-800 number. It's completely free, so you can call in or go to our portal, zerocancer.org/0360. If you have issues with your insurance, other financial obstacles that you need to get over, if you have a dispute with your insurance company, if you're trying to keep the lights on and also fight to get your treatment covered, give our line a call, go through our portal. You get hooked up with a patient navigator. As I said, it's all free, and they'll go the extra mile every time to be able to help you out and solve any and all issues that you have as you go through your treatment. Fighting prostate cancer is hard enough, and with all these other things that go on as we fight prostate cancer, it's an extra benefit to have an additional team member on your side. Another thing to consider for those who are fighting metastatic prostate cancer is Zero's Decode Your Prostate Cancer program for eligible patients. We'll work with our partner to get a molecular profile. Again, it's completely free, and it's a tailored plan to be able to determine what mutations are driving your prostate cancer, and it's in partnership with Bethera, which is a leading company in precision medicine. Other ways to get involved, Zero is here. Our website is zerocancer.org. We have a monthly newsletter that you can subscribe to that has the latest and greatest of all the information that both Dr. Morgans and Colonel Taylor shared. We'd love you to participate more with Zero. You can reach out and volunteer with us at any time and connect with us on social media. We have a Facebook page. We have a Twitter account, at Zero Cancer on Twitter. Same for Facebook. And with that, let's move over to questions. So we have a patient that writes in, Dr. Morgans, that says, I've been on Lupron since January, and Casodex was added in September. Within the last month and a half, I've been getting soreness in some of my finger joints. My doctor says it seems to be trigger finger, quote unquote. Could this be caused by the medications I'm on treatment with for my prostate cancer?
So great question. Thank you so much for asking it. Things like arthritis can certainly be worsened by androgen deprivation therapy, having low testosterone levels. It doesn't sound exactly like you're having arthritis, though. If you're specifically having something called trigger finger, sometimes that can be treated with steroid injections into the joint to loosen that up, and that's more of what we would think of as a rheumatologic disease, more of an inflammatory autoimmune type process. What I would say is that if things like regular ibuprofen or Tylenol are not making that specific issue better, you probably should talk to a primary care doctor and maybe see a rheumatologist to see if you can have an evaluation to see if you might benefit from a steroid injection if you truly have trigger finger. And that's probably unrelated and may just be related to stress that you're experiencing or just be a process that you were going to develop anyway. I know that there's a temporal relationship, so I would never say that it's never related, but the treatment is is more of a specific treatment that might involve steroids directed into the joint if it's truly trigger finger. So I would pursue that and see if you can get some help maybe with a specialist.
Thanks, Dr. Morgans. We also had a question asking to elaborate on immunotherapies with using antibodies to fight your prostate cancer.
Using antibodies to fight your prostate cancer? So I'm wondering if the person asking the question might be asking about things like pembrolizumab, atezolizumab, durvalumab. These are PD-1, PD-L1 directed antibodies, immunotherapies that have been approved recently for multiple other solid tumors like bladder cancers, melanoma, renal cell cancers, and some other things. These are not, at this point at least, effective therapies for prostate cancer. There are studies ongoing, but unfortunately prostate cancer does not seem to be responsive to those therapies alone. Prostate cancer was fortunate enough to be the first solid tumor to have an immunotherapy approved by the FDA for it. But that's Sipuleucel T, which is not an antibody. It's this, this process that we discussed earlier where white blood cells are removed from an individual's system. They're trained and educated to fight prostate cancer cells, and they're reinfused. So there's not an antibody there. It is a training of an individual's own immune system, and then it's a reintroduction. But traditional or the newer therapies that are PD-1 and PD-L1 directed do not, at this point at least, seem to be effective in prostate cancer on their own. Definitely work being done to see how we might be able to use them in the future.
Great, thank you, Dr. Morgans. I have another patient writes in that says he's been living with metastatic disease for over 8 years. He's 72, had robotic surgery, followed up by radiation, and is now on Eligard. Has all the side effects, but is very, very healthy and exercises and eats only healthy foods. Any thoughts on what he should be focused on going forward?
So it sounds like he's doing really well. It's important to have a diet that is a heart-healthy diet, one that's low in red meats, low in saturated fats, high in fruits, vegetables, and whole grains, and try to be as physically active as possible, doing certainly weight-bearing activities to maintain good bone health, doing some cardiovascular type aerobic activities if that's acceptable for an individual based on an evaluation by his own primary care doctor who makes sure that he's safe enough to do those kinds of exercises. But being as physically active as possible is always a good thing. So it sounds like he's on the right track. Did I miss? Was there a problem in there anywhere, Jamie, or is he just he's just doing his best and asking for more advice?
Just proactive.
Well, he is. It sounds like he's actually very aware of what he needs to do. So I would just encourage him to keep up the good work.
Great. I have another patient that writes in that says had a radical prostatectomy in 2012, followed by 6 months of Zoladex in December of 2014. His PSA now, as of December right now, started to rise again recently, and wondering what you would consider the best way forward. You had mentioned that it is still possible to gain a cure. Is that using a combination of drugs?
So I don't know this patient's specific situation. I'd certainly have to look at all the records and those kinds of things. Sometimes in some very specific settings for biochemical recurrence after a person has had surgery, we can use radiation to potentially cure that individual. But in most cases, I would say we can't cure the disease. But this person should certainly ask that question of his doctor because you should never leave a stone unturned when we're talking about your life. And if you don't feel comfortable that you've gotten the advice that you need from your individual doctor, then get a second opinion. I would say, I have so many patients that come to see me regarding second opinions, and they're worried about hurting my feelings or hurting the other doctor's feelings. At the end of the day, none of us none of us are insulted by these things, or I would say a good doctor is not insulted by someone getting a second opinion. It's your life, and you need to feel like you're doing all that you need to do to sleep at night. So I am never offended, and I assure you that 99.9% of doctors are not offended if you need to ask another person's opinion. And it can be as easy as that to give you the peace of mind that you need to make these tough choices. So again, I wish I could answer your specific question. Sometimes we can use radiation after surgery to cure people, and we often combine that with hormonal therapy. It sounds like you've already had some Eligard. But I don't know your specific situation, so I really can't say exactly how you should move forward.
Thanks, Dr. Morgans. Speaking of rising PSA, Paul, not to put you on the spot, what do you see as next for you if your PSA goes up?
Yeah, good question. So I've already lived through one recurrence. So, some of the advanced hormonal therapies that Alicia mentioned earlier, abiraterone and enzalutamide. I took abiraterone for about a year and achieved a pretty good effect, but after I had a recurrence, I moved on to enzalutamide. It was sometimes called Xtandi. And, I've cycled through most of the things. But, I think for me, the questions that I'll start asking if I have a recurrence again are whether I can potentially recycle through some of the drugs that I've already taken to see that I can keep the cancer off balance and potentially returning to a drug that I already took and trying it again, doing another round of chemotherapy even, participating in a trial. So I think even at this stage where for a person like me that's been through most of the traditional and even some of the newer treatments, I think there's a ton of things that you can think about, even in terms of cycling back. I mean, I've even heard of folks that, have good results sometimes with ketoconazole. After they've done a bunch of the much newer treatments, they go back and try ketoconazole again. And I think it's all about, the cancer eventually learns how to adapt and respond to whatever treatment that you're on. I mean, this is it's a very complex but difficult problem to solve in terms of prostate cancer. But the way I think about it sometimes is by always if you're cycling quickly and making sure that you never give the cancer enough time to respond and trying different things and hitting it from different directions, you're probably gonna have the best chance of success. So don't be afraid to go back and think about older things, even if you've already gone through some of the newer things. I don't know. I mean, maybe Alicia would disagree with me a little bit, but from a patient's perspective, I think that you got a big menu, and you should continue to use all the tools at your disposal.
I would agree with you, Paul. You've got a lot of options, and clinical trials are always on there too. And I would say it's always good to be creative, and it gets back to the point that Paul made. Be comfortable enough with your doctor that you can ask these questions, because there's not really a wrong question that you can ask. And sometimes I do this every day, all the time. I'm constantly thinking about how can I evade the next prostate cancer cell? How can I trick this one into falling for whatever treatment I'm going to give it? And patients bring things up, and I say, you know what? That's why don't we give it a shot? That sounds like that's a great idea. So make sure you talk to your doctor. Think creatively. If your doctor says no, it's probably for a good reason, but just ask, why. And I bet you he or she will explain it's not safe to do this, or it's not, I can't do that because of whatever the reason is. But in many cases, he or she might say, why don't we give it a shot? Let's see if that works. So it's interesting. I so appreciate Paul's perspective of approaching it too. It sounds like you're doing battle with these cancer cells, Paul. Just it's nice to hear your how you think through treatment.
Now, thank you both. Now to flip it on its head, is it if you have undetectable PSA for a number of years, is it ever viable or advisable to go off androgen deprivation therapy?
So that is the age-old question, Jamie. And the other part of that is, if you are off androgen deprivation therapy and it remains undetectable and you only have localized prostate cancer to begin with, can you ever take testosterone? That's the other question that I'm asked. So those are very personal and individualized questions and personal and individualized answers. And so, again, important questions to ask as a patient and to have those conversations with your doctor. I can't give any advice, generalizable advice, but in some situations there are patients who have metastatic disease that I treat that do come off of therapy. It is very specific situations. It is typically in the setting where I explain you may not live as long if you come off of therapy, but I recognize that you're trying to balance quality of life with length of life, and if that's what you choose to do, we can, make decisions and about how and when we want to attack the cancer again. And there are people who I end up treating in that way, and there are definitely people who I know, I don't typically do this, but I have colleagues who do many years after a prostatectomy, for example, if the disease hasn't come back, who think about giving testosterone supplementation for quality of life purposes. So, these are important questions that men should have with their doctors. And again, don't be afraid to ask these questions.
Thank you. Now, Dr. Morgan, is there a treatment on the horizon or a potential breakthrough that you're most excited about or interested in?
So I would say there are a lot of really exciting things coming down the pike. A lot of them have to do with combinations of existing therapies, combinations of things with immunotherapies like the PD-1, PD-L1 inhibitors that we're all hopeful as combinations may be effective in prostate cancer. I would also say there's a slew of new androgen receptor-directed therapies, so anti-androgens, that are coming out that seem to have a better side effect profile than some of our earlier generations and just probably are equally effective in terms of controlling the cancer. And then I'm very excited about using combinations of medicines earlier on in the disease spectrum to try to get more bang for our buck out of them. In the very advanced disease setting, they're effective, but they seem to be even more effective when used sooner and maybe synergistically so when used in combination. So lots of things on the horizon, and I think that we are only in for hearing exciting news in the next few years. I think it's going to be a great time in prostate cancer research, and to help men feel better certainly is one of the key goals.
And one last question that we have. What's your opinion in terms of testosterone supplements increasing the chance of prostate cancer?
So there was actually some recent data published by a woman and her group, Stacy Loeb. She is at NYU, a great researcher and urologist, and she also, I think, has a radio show on Sirius about men's health. But she published a really interesting database analysis that did not find an association between exposure to testosterone supplementation and increasing the risk of prostate cancer. For anyone who's interested in doing so, I would say, do that under the care of a urologist who's monitoring you closely. Make sure that you don't have prostate cancer when you are thinking about starting testosterone supplementation, but done in the right way. It actually appears to be quite safe, but really does, as I said, need monitoring and counseling and follow up.
Thank you. And just as a reminder to everybody who's tuned into our webinar tonight, this program has been recorded, and it will be available on Zero's website, zerocancer.org, within the next couple of days. You can also go to our Facebook page, where we have broadcasted it live. It stays on the page. If you're still always getting to know what social media is all about every day, like I am, know that it's also housed on there as well, and you can watch it, rewatch it on there as well, and share it with your network and your family and your friends. Thank you so much, Dr. Morgans, Colonel Taylor, for being with us tonight and sharing your experience, your expertise, and your perspective. We'd also like to thank our sponsors, Dendreon, Astellas and Pfizer Oncology for supporting our program tonight. And thank you to everyone who came out to join us. Please take your time. As soon as we end the program here, there'll be a post-program survey that will come up. You'll be prompted for that in just a moment if you stay on. And we very much value your feedback, and it helps us plan our future programs, determines what topics we're going to cover in the future with our webinars, and it helps improve our series. And that concludes our webinar tonight. Thank you again, and happy holidays to everyone.
Thanks so much to everybody. Good night.
Thanks, everybody.